Hello class, welcome to the preparatory lecture prior to IC4, and we'll be covering sequelae and clinical diagnosis of hypertension at this time. Alright, here's an overview of what we'll be covering. We will be talking about the sequelae of hypertension, how hypertension is diagnosed, and non-pharmacological prevention and management of hypertension. By the end of this session, I do hope that the attendees will be able to describe the impact of the non-pharmacological strategies in prevention and management of hypertension. You can list the sequelae of untreated hypertension and discuss how hypertension can be diagnosed. Alright, so before we go on, let's recap some key points. Okay, first concept, systolic blood pressure. The systolic pressure really measures the pressure in the arteries when the heart beats and when the ventricle contracts, right? The left ventricle contracts. So this is represented by the top number when you see a blood pressure reading, and in this schema over here, you can see the 120 actually refers to the systolic blood pressure. The diastolic blood pressure refers to the bottom number, and this is when the pressure in the arteries are measured when the left ventricle relaxes and is filled with blood. Okay, so let's recap on the determinants of blood pressure. Blood pressure comprises of cardiac output and total peripheral resistance. So the cardiac output is also determined by the amount of stroke volume as well as the heart rate, right? Therefore, the contractility of the heart and how much the heart fills will determine your stroke volume and therefore your cardiac output as well. Okay, so that's how you get a higher blood pressure when you've got better stroke volume and also when you have a stronger heart. So essentially, on the other side, where the TPR is concerned, is this measure of the resistance of your peripheral arterial zone tones, right? So the more constricted your arterioles are, the more likely your TPR is raised, and therefore your blood pressure is also high. And so this is the background on which we will be talking about drug. Okay, so let's add on an additional concept, and we look at the schema over here. What's determined on the left-hand side is really the cardiac output, right? So we're talking about potentially defects in renal sodium homeostasis, whereby there's an increase in plasma volume and ECF, and that's why you get an increased cardiac output. Likewise, on the other side of the house, where you get environmental factors or genetic influences, you may end up getting functional vasoconstriction, maybe in a setting of stress, prolonged stress. Or you could get defects in vascular smooth muscle growth and structure, therefore increasing vascular wall thickness, and vascular reactivity as well as increased vascular wall thickness would then lead to an increase in total peripheral resistance. And so these two factors put together will give you high blood pressure. So what are the risk factors that could determine a rising blood pressure? One of them is aging. The other is potentially high sodium intake for people who are salt sensitive. And then on the reverse side of the house, I want you to think about dehydration and heat stroke as well, where your blood volume is reduced or shrunken. That could lead to a reduced cardiac output, and that's why you get hypotension in the reverse order when you actually see people with dehydration or heat stroke. Okay, so how common is hypertension in Singapore? If you look at the prevalence, just maybe a spread of 18 to 69 years old of all Singaporeans, that maybe prevalence rates about 20% if you see the red bars over there. However, if we're talking about people above 60 years old, the prevalence of hypertension was as high as 74%. Can you imagine? Like 8 out of every 10 persons that you know could be hypertensive. The rate of hypertension was associated with the older age, lower education, higher BMI, the Malay ethnic group, the retired, and very interestingly, there were people who were very physically active that were unaware that they were hypertensive as well. So, ladies and gentlemen, it's very important that we recognize that hypertension is often called the silent killer. Why? Because typically there are no symptoms, and usually by the time you know that you have hypertension, you usually present it as like complications already. For example, when you have target organ damage, maybe as kidney impairment, or you may have heart failure or cardiomyopathies, right? And severe hypertension can present with symptoms such as headaches, pulsating behind the eyes, usually early in the mornings, and visual changes, blurred vision, as well as nausea and vomiting. And you actually should be so lucky that you present with such symptoms, because then it will cause you to seek medical attention. But most times there are no symptoms that leads to a delay in the diagnosis of hypertension. So we talk so much about hypertension, you might say, yeah, so what about hypertension? What is its clinical sequelae? So upfront, we'd like to mention that every 5 millimeters mercury reduction in the systolic blood pressure is proportionate with a 10% reduction of CV risk, and that's seen in the meta-analysis in the link over there. From the BP cutoff of 115 over 75 millimeters mercury, CVD's risk actually doubles with every increase in 20 over 10 millimeters mercury. That's actually equivalent to treatment of 2 drugs, right? Every 5 millimeters mercury systolic blood pressure reduction is proportionate with 5% reduction in death from CVD. Every 5 millimeters mercury systolic blood pressure reduction is proportionate to 15% reduction in CV risk, and likewise 13% reduction in the stroke risk. Now, I want to bring to mind that the stroke risk reduction is critically important in Asians. Why? Because Asians are not Caucasians, right, boys and girls? The most important thing is stroke, right? Especially hemorrhagic stroke and non-ischemic heart failures are very common outcomes in hypertension-related cardiovascular disease in Asia. Now, blood pressure and cardiovascular disease association seems to be higher in Asia than in the West. So this Asia-Pacific cohort studies collaboration, when comparing New Zealanders and Aussies compared with Asians, was able to show that a small increase in the BMI was associated with more pre-hypertension in Japanese and in the Westerners. So it seems like we are more sensitive to BMI changes than Westerners are. Now, there's also thought to be a higher salt sensitivity in Asians. This is more likely to be because of a salt-sensitive gene polymorphism of the renin-angiotensin system. Now, it's also thought that the initial focus for Asian population should be on the morning control of blood pressure and then followed by the nocturnal BP. So this is important where we are concerned because we want people to also measure their blood pressure twice a day, and there may be important insights as we discuss later when we talk about somebody who comes to clinic and the blood pressure is at goal. What about the night BP? That may be something that suggests to you that's why their kidney function is still deteriorating over time. So with this chart, I don't want to belabor the point. I think suffice to say that's a huge benefit of treating hypertension. A 10 millimeter mercury reduction in systolic blood pressure can significantly reduce the risk of several conditions like coronary heart disease, stroke, as well as heart failure, and the percentages are over. So you might see these classifications or categorizations of what is considered high blood pressure. Now, I'd like to bring to your attention that these BP categories, or hypertension or pre-hypertension, or even how high the blood pressure readings are before you consider them as hypertension, can differ from guideline to guideline, and the Western guidelines or the Caucasian guidelines tend to be a bit more aggressive than our local guidelines, which we will also look at a while later. So now, what's the concept behind primary versus secondary prevention? How and when do we treat our patients with hypertension, right? So it's always about the benefits versus risk. And when we're talking about essential hypertension with no other compelling comorbidities, then we're talking about people who are prior to established disease, right? We need to risk stratify according to the presenting blood pressure and concomitant risk factors in order to determine when to start medication and then how much to treat them to with respect to the blood pressure goals. Now, when you have actually comorbidities or coexisting diseases that coexist with your hypertension, that's actually the easiest situation, which is the paradox of this whole matter, right? So if you had, for example, established atherosclerotic disease or ASCVD, or if you have compelling indications that drive the choice of antihypertensives, for example, you could have nephropathies due to diabetes, then you could be maybe saying, okay, the first line should be ACE inhibitors because the evidence is clearer with that group of agents as opposed to, say, calcium channel blockers or dihydropyridine calcium channel blockers. Ironically, those with comorbidities are actually more straightforward for you to choose the agent, and so it actually makes your job easier. So we're going to shift into primary prevention of essential hypertension next. Okay, so in this slide, I'll cover various types of risk scoring and stratification. In this schema over here, you see the European risk score, and this is calculated through this particular link at the bottom. So you put in various risk factors like maybe you're pre-diabetic or your BMI is high or various other risk factors, right? And it spits up a risk score for you, which helps you to determine when you start treatment for antihypertensive therapy and how low the target should be. Likewise, the ASCVD risk estimator, right, is seen in this particular screenshot over here, and the link is at the bottom if you want to give it a shot. So similarly, the approach is to put in the risk factors like age, systolic blood pressure, total cholesterol readings, whether you've got history of diabetes or smoker, etc., etc. And you can actually recognize that these are risk factors for cardiovascular disease, right? So once people put this in, right, it will spit out a risk score for you, and it will also recommend to you when you should start treatment and how high or how low the target should be, how high the dosage should be. So this is necessary only in a setting of primary prevention, mainly because as I mentioned earlier, in secondary prevention, it's very clear when you have comorbidities that you need to use drugs, and you also treat at a lower threshold. And primary prevention, you kind of have to aggregate the risk, right? Because we always talk about benefits versus risk. And if somebody is not at very high risk, right, why would you want to subject them to a lifelong antihypertensive, regardless of how safe the safety profile is? Because we always talk about really minimizing those risks while benefiting them in terms of the maximal benefits, right? Okay, so let me demonstrate to you how the ASCVD risk calculator works. And I chose this only because it's convenient to show you how the risk calculator spits out the information for you. So say, for example, I've got a patient with all these baseline parameters, and we put them in. He's calculated 10-year ASCVD risk is actually 5.7%, right? And so if basically when you click the enter, it will come up with this particular recommendation that if you start BP medication, then the ASCVD risk score will drop from 5.7% to 4.1%. And if you treat it with statin therapy, then the 5.7% will be dropped to 4.2%. So this is how sometimes you would offer patients, particularly if the baseline ASCVD risk is very high, right? You kind of show them, oh, if I start blood pressure medicine, this is what your ASCVD risk will become. Or if I start you on statin therapy, this is how it will become. So to me, it's a very good conversational piece, especially if you are carrying out some sort of shared decision making. Because you're then able to quantify the risk and basically to explore with the patient what's important to the patient or the person that you're working with. And likewise, if you look at how the various factors weave in, right? So this particular table shows you if you start statin alone, then the baseline risk score is dropped to 4.2%. However, if you start statin plus say a BP drug together, that's dropped to 3.1%. Okay, so this is how risk calculator works, and I find it very useful to have a conversation for patients, particularly if they have got primary prevention type of a story, they don't have a heart attack before, and there's nothing that they need to fear, particularly when they are young. So back home in Singapore, we also have our own guidelines, which was published in 2017. And in this particular guideline, the authors have written out prognostic factors for cardiovascular disease. And you can see that there are additional risk factors that you need to be considering. And so this is also the same principle by which the risk scoring in aggregation works with respect to whether it's the risk score, or whether it's the ASCVD risk calculator, except that in Singapore, we unfortunately don't have a calculator that's so fancy like the Americans do. And then if you have target organ damage, and I mentioned that earlier, right? So what they consider to be target organ damage is what is a complication of long-standing hypertension. And so cerebrovascular disease is considered a target organ damage, and to me that is a compelling indication of when you need to start your blood pressure, and you lower your threshold for when you need to start treatment. Renal disease, heart disease, which is like left ventricular hypertrophy, for example, is where I told you before that the heart has to work at very high pressures, and just like how the boys go to gyms to pump up iron to bulk out their muscles, it's the same for your heart because it's a muscle. If you have long-standing hypertension, your heart will be forced to pump against very high pressures. It's almost like lifting weights in chronic terms, right? So your heart becomes hypertrophic, or the muscles become hypertrophic. And this is how you get left ventricular hypertrophy. And in time, this becomes like a situation where you get a heart failure state of things as well. So there are other types of target organ damage examples. And like we mentioned earlier, there could be vascular disease, for example, aortic aneurysm, where your aorta starts to expand out because of the weakened wall. You could potentially also develop peripheral vascular disease as well as hypertensive retinopathies. Remember, I was just telling you that it could cause visual loss as well. And also atherosclerosis has been associated with the clinical condition with hypertension, long-standing hypertension. Right, so with this slide, I just wanted to put side by side the European guideline recommendations and the Singapore guideline recommendations. One was published in 2018 and the other in 2017. So by and large, if you look at the grading and the classification of what is considered grade 1, grade 2 for hypertension, right, they're both in agreement. And so I suppose we could routinely say that across the world, the guidelines all agree that grade 1 hypertension potentially could require you to think about treatment, especially see if they have got at least 1 to 2 risk factors where the European guidelines are concerned. So you can look at how the European guidelines are slightly more aggressive than the local guidelines. We tend to be a bit more permissive. For example, if you look at, say, grade 1 hypertension, which is 140 to 159 systolic blood pressure, and we're talking about 1 to 2 risk factors, it's considered moderate risk for the European guidelines, whereas it's still considered a low risk for local guidelines. And so you can see that local guidelines basically is a bit less aggressive and will want to wait out a little bit more. So for people with very high or high risk factors, we are talking about, say, symptomatic cardiovascular disease, and when we mentioned earlier, right, which is target organ damage, chronic kidney disease, stage 4, or diabetes mellitus, that's when you're considering people very high risk. And so these very high risk people, there's no doubt about it, you've got to treat already. And then for people with established cardiovascular or renal disease, the Singapore guidelines asks you to watch and wait. I'm not that sure if somebody's blood pressure was like above 160, I probably would have started treating them already. So I can't say I quite agree with watching and waiting, because it's quite clear that long-standing hypertension is going to be deleterious on the body. Where people are considered low risk with the Singapore guidelines, that's what they're saying to maybe monitor again, like give an appointment a couple of months down the road to give the person a chance to maybe modify those risk factors, like lose some weight or reduce salt intake, and then that would also modify the risk of a person. So with respect to the recommendations, there are the snip at the bottom, which you can read at your own time. As to whether we should follow the European guidelines or the Singapore guidelines, I would say that it is probably better to follow the American or the European guidelines, mainly because the data that they reflect tend to be a lot more recent, and there's been a lot of recent data to suggest that the lower the blood pressure, and up to maybe even 120 something, 130, the better the clinical outcomes with respect to cardiovascular deaths. Okay, so the golden question is always to treat or not to treat, and it gets confusing when you compare the various guidelines. With respect to how the European and the American guidelines approach things, I think in general, it's quite clear that the moment you've got ASCVD risk factors, right, you should always consider treatment anyway, regardless of where they're at. Even at stage 1 hypertension, you should be thinking about whether they should require treatment or not. Okay. It's only when you don't have ASCVD risk factors or ASCVD equivalents or high-risk patients that you start to rack your brains as to when you need to start therapy. But I'd like to call to attention that regardless of whether you start therapy or not, for all grades across all the presentations of hypertension, it's important to administer lifestyle advice. And we'll cover a little bit about what the lifestyle advices should be when we in the subsequent slides. But if you look at both sides, right, you're talking about the green boxes on the right-hand side for the American guidelines. They say likewise that non-pharmacological therapy should also be observed over and above whether you should start therapy or not. So where the American guidelines are concerned, they give you the time frame of when you need to reassess and when you need to consider starting therapy. So that's a bit helpful where the American guidelines are concerned, and slightly more helpful than the Singaporean guidelines as well. Okay, so here's a key concept that I want everyone to remember. There's several non-pharmacological management that everyone needs to be very, very aware of, and this is called out from the Singaporean and hypertensive guidelines here. Essentially, they're talking about lifestyle changes to all hypertensive patients and in all patients with high normal blood pressure, and the drug treatment should not be delayed without reason beyond 3 to 6 months if indicated. And so it's actually written in the print here when you read a bit further, so you kind of have to remember it as opposed to the flow chart that you saw earlier. It is also necessary to advise patients to restrict salt intake to 5 to 6 grams a day, moderate alcohol consumption, that's the alcohol intake, where the consumption of fruits and vegetables are concerned as well. And then the very important thing that I want to point out here is the BMI. Now in Asians, we consider BMI below 23 as non-obese, whereas in Caucasians, the cutoff is really BMI of 25. There's also an additional parameter that we look for in Asians, and that's particularly the waist circumference for men versus women. And this is an indicator of what we used to call metabolic syndrome. This is also an important thing to be thinking about, because those with abdominal obesity are also at risk with respect to hypertension and cardiovascular disease. Okay, so furthermore, you also need to tell your patients to observe moderate dynamic exercise at least 5 to 7 days a week. I know not many of us can do that. I don't profess that I can reach that, but I try to at least do a bit more on the days that I can exercise, at least 30 minutes a week. Now remember that if you have a very frail auntie or very fat patient, please don't try to insist that they have to do this, because it's going to be impossible for them to get from 0 to 5 to 7 days a week, right? So this is where the shared decision making process is concerned, working with patients as to what they are capable of carrying out. And if you were a pharmacist and stay in a community setting, it's also opportunistically a good time when you're dispensing medications, right, to tell them about all these lifestyle observations. And especially if they bring up these risk factors with you, kind of can start a conversation and remind them that these are important things to also watch out for. And of course, most importantly, offer assistance to all smokers. Remember, because smoking actually has got chemicals in the cigarettes that causes vasoconstriction. And remember, vasoconstriction increases TPR, right? Therefore, you can also cause hyperpressure. So once you stop smoking, you actually realistically can reverse hypertension sometimes. And it's also important to then modify all these risk factors in its totality. Okay, so this is a key concept I want everyone to remember. Regardless of drug treatment or not, it's still important to observe non-pharmacological management. Now, remember that in the earlier stages, before anyone is considered hypertensive, right? Remember the high normal, which is like 130 to 139, that's not really considered hypertension yet. That's when you need to enforce pharmacological management before the time that you repeat the blood pressure again in 3 to 6 months, so that then that's where you reassess risk factors and then decide to start drug therapy as needed. Okay, so I particularly like this chart, right, because it gives you a corresponding approximate benefit of blood pressure reduction for every risk factor that's non-pharmacological interventions for the prevention and treatment of hypertension. And so it's actually a worthwhile conversation, right? I remember even bargaining with my patients before, like I kind of say, oh, you know, if you lose weight, 5 kilo reduction will reduce your blood pressure by 5 millimeters mercury. Actually, if you lose 10 kilos, right, that's equivalent to taking one drug, you know. So you can potentially, if you lose 10 kilos, right, I can even maybe potentially consider taking off one medication for you, you know. So that's the benefit, right? So I remember I had this very fat auntie, 110 kilos auntie. I used to remember bargaining with her this way as well. So that actually contextualizes what you're trying to say to your patients sometimes also, and you can use that as a handle to convince your patients to modify their lifestyles. Okay, so you can potentially also ask them to observe a DASH dietary pattern. Imagine a diet rich in fruits, vegetables, whole grains, and low fat products, right? Can reduce your blood pressure by 11 millimeters mercury, you know. Isn't that impressive? Also, reduction of dietary sodium for people, especially if they're salt sensitive. An increase in dietary potassium can potentially also drop blood pressure by 4 to 5 millimeters mercury. Okay, so in this second chart, right, you can see further suggestions of what non-pharmacological interventions could mean. They are physical activity that you can increase, whether it's aerobic exercise or resistance type exercise. You can also preach the moderation of alcohol intake with respect to alcohol consumption. So you can start to imagine and picture up in your mind the accumulation. If you've got multiple poor habits when you have poor lifestyle, a lot of them can stack up, right? And so your blood pressure can collectively be raised because of the poor lifestyle practices. So also remember not to nag your patients to death and list out to say, oh, you've got so many things that you are not doing well, but also work with them with what they think is modifiable right away, or what they prioritize to be what they can achieve. There's no point talking down to them and nagging them to death, because it will then turn them away and not make you like the trusted healthcare professional anymore. Okay, so the take-home message here is that if you're dispensing to a person and you know that the new medications started for blood pressure and all that, it also gives you an opportunity to talk to your patients about the benefits of lifestyle changes in reducing blood pressure. Maybe think about giving them the question on what I can do to improve my blood pressure resource as a reminder for doing better with the blood pressure control. Okay, so now that we've talked about to treat or not to treat, the how to treat will be then in IC6, and in IC5, Dr. Mitchell Lai will then take you through the various pharmacological classes of what we can choose. Okay, then we'll revisit this in IC6 when we talk about how to treat. So then this little segment is about how to recommend cuff sizes and measure home blood pressure. And I can't belabor the point about how important home measurement of blood pressure is. So we will be talking about the special group of patients with potentially white coat hypertension. And white coat hypertension is a situation where you see healthcare professionals like doctors or pharmacists, your blood pressure actually is higher in the clinic setting than at the home setting where you're all relaxed, right? And some people don't even feel anxious. They can have their blood pressure even raised in the presence of a healthcare professional. And this is fairly common in our elderly patients because they tend to be I guess more reactive towards the situation even though they don't feel overtly anxious. Okay, so it's critically important to teach a patient how to measure blood pressure at home. And remember there was a scenario earlier that we talked about the people whom will wait for a while before we start therapy, right? It's also important for them to measure their home blood pressure just to see whether the clinic blood pressure and the home blood pressure is in sync or not. Sometimes it could also be because they have an existing blood pressure meter which is not so accurate, and then those are also opportunities if you're working in a retail setting or a community setting to ask them to bring their blood pressure to you so that you can be on the spot, right, calibrating the blood pressure, their blood pressure meter for them in your pharmacy setting. Alright, so let's talk about a little bit more about Spigon manometers. And those of you who have undergone the practical, you have already used the aneroid meter and you know what that is, right? So there's a different type of manual Spigon manometer, which is a mercury meter. And this mercury meter is slowly being phased out now, mainly because of the fear of mercury spills due to the breakage of the capillary over there. And because it's cumbersome and heavy, a lot of times people have switched to the use of aneroid meters as well. Okay, those are the manual reading meters. Now, remember the theory behind how the blood pressure cuff reads your blood pressure, right? So as you inflate the cuff will then cause a stop in the blood flow in your blood vessels. And as you slowly release the pressure in the cuff, the first hard sound is when the blood starts hitting the blood pressure vessel walls again. That's when you hear the first Korokov sound. And then when the whole Korokov sound disappears, when the whole blood lumen is wide open and there's smooth flow again, that's when the sound disappears, and that's your diastolic blood pressure. Okay, so remember the science behind how the Korokov sounds are being produced and how you picked up using a stethoscope. Okay, and then with the advent of automatic meters, that makes things a lot easier for us, right? It's not so troublesome. They've got to go inflate a meter and then listen very hard for the changes in Korokov sounds. The automatic meter has its own limitations, which we'll talk about a little bit later. Now, in a hospital setting, they can potentially have very expensive meters. I was told in our previous practice place that the electronic blood pressure meters in the clinics could cost up to $3,000, and that is supposed to circumvent some of the limitations with the automatic blood pressure meter that we'll talk about later. Okay, in this slide, we're going to cover BP monitor cuff sizes. Why is this important? Now, the inappropriate cuff size is the #1 cause of inaccurate BP measurement, okay? Whether it's undersized or whether it's oversized. Now, if it's undersized, it'll be too tight and it will cause a falsely high blood pressure reading when you try to pick it up. This could also apply to your automatic blood pressure meters. Now, if it's oversized, then it causes an under-reading of your blood pressure, mainly because it's too loose, right? That's common sense. Now, the adult cuff size, when you try to recommend a cuff size, always watch out for people who are on the big side or on the fat side. Of course, don't be so insulting to say you're fat and therefore I need to measure your arm size, but kind of remember that the arm circumference for a normal usual adult is between 22 to 26 cm for the usual cuff size that's over the counter. So if anyone has got an arm circumference that's larger than that, you will potentially need to order a special cuff size for them. Okay, so where the cuff size is concerned, it's important that the width here, right, the width of the cuff is about 37 or 1/3 or to half of the limb's length, right? So if the arm is really very short, then you need to be looking for a cuff size that is shorter this way in the width. And the bladder needs to wrap around your arm by at least 3/4 to 100% of the circumference. And when I'm talking about the bladder, I'm talking about the pink part over there with the label on the top, bladder length. Okay, so remember for special populations that I mentioned earlier, right? For obese, if they're really very big and there's no way you can measure their blood pressure in clinic because the cuff sizes are just simply too small, and I remember having several patients like that before, you can potentially measure the forearm, which is the lower arm here, or sometimes people can use wrist meters that you place at the level of your heart. Okay, so one of the difficulties with wrist meter is that if you put it in anywhere other position, remember by the principle of the pressure reading, right? If you place it any other levels, then the readings are not going to be accurate. Okay, so if you place your wrist meter under the heart, right, then it overreads, right, because the pressure is actually higher than your heart level. Okay, when you place it over the heart, then of course the pressure is lower and therefore it will underread as well. Okay, so for the pediatric patient, I can't profess that I'm an expert with that, but the right arm blood pressure is usually preferred unless there's a coarctation of the aorta, which is a congenital issue. Or the limb blood pressure can also be used if the person is supine or sitting upright. Okay. Here I want to cover the tips for monitoring blood pressure at home. I think it's very important for us to give the right instructions to our patients. And a lot of times our patients will anyhow sit, right? Or maybe they forget those rules and they end up having blood pressure variations along the way. And this becomes important because when you review the blood pressure trends, particularly in clinic, right, that's when you want to decide whether to titrate their medications. So it's very important that they measure their blood pressure accurately as well. So you might want to tell them to take their blood pressure twice a day, and preferably once before breakfast. I usually tell them when they wake up in the morning and they've voided their bladder, it's a good time to take their blood pressure. Remember that when you're urgent, right, your blood pressure can be raised, right, because you're ganjong, you know, and then so you try to do that, and then you try to measure blood pressure before the administration of medications, just so that you can see the overnight impact of blood pressure. Okay, don't try to exercise at all before trying to take the blood pressure. And if you do the same in the evening, avoid the administration of exercise prior to taking blood pressure. Measure at the same time every day. That's very important, because I have had patients who tell me, yeah, I measure in the morning, then in the afternoon the difference is so much. How come there's 10 millimeters mercury difference? Well, the blood pressure has got a variation in rhythm to it, right? If you particularly are moving around a lot in office, clearly it's going to be higher. Remember to ask them to avoid food, caffeine and alcohol intake about 30 minutes prior to measurement. Sit quietly, and during monitoring, right, sit for about 5 minutes with the legs and ankles uncrossed. Okay, very commonly you see patients with their legs 翘这边 or the ankles are crossed, and the back should be supported against a chair. They need to stay calm and don't talk while taking blood pressure. You know, you've seen people who, like, you know, fling the arms around, they talk around, talk to people when the blood pressure is being measured. That will cause an overreading of the blood pressure. Yeah, I remember having very talkative patients like that, and the blood pressures are always very hard to take because they're very talkative and they fling their arms around. It's important to place the cuff on bare skin, not over clothing, because remember, you want the cuff to be able to pick up the closure, or rather the appearance of the Korokov sounds and the disappearance of the Korokov sounds. So because it's automatic, it's not like you've got the stethoscope to try and mark where the points are. If the bladder cannot pick up the correct start and end of the Korokov sounds, it will end up being a poor reading of the blood pressure readings. Okay, avoid rolling the long sleeves up, because if you imagine, if you roll the long sleeves up, right, then there's a lot of material here. So as you put the cuff over, it will overly constrict your blood pressure on its own, rather than corresponding to the pressure that the cuff is configured to pick up. Okay, so that's a logical common sense of why it should prefer not to roll the sleeves up. So I do recall that I've got quite a lot of Malay patients, because they always cover up all the way to the wrist. So for the Malay ladies, for example, hopefully they're wearing loose clothing that could cause you to roll it all the way up, and make sure it's clear of clothing before you put the cuff on. There have been times when I have no choice. I've had to put the cuff over their clothing and pray very hard that the blood pressure readings are somewhat equivalent. So that's why it's important for you to counsel them for the home blood pressure, because that's where they are at rest and they're not stressed out. They are unlikely to be predisposed to quite poor hypertension. Their home readings are usually more accurate than the clinic readings. Okay, so if they were coming up for appointment, right, then it's important for us to tell them that they should probably measure 7 consecutive days readings prior to coming, and preferably if they really cannot remember, then keep it to 7 consecutive days prior to the next appointment, just so that they give the clinician a sense of where the blood pressure trends are, to make better decisions with respect to the drug therapy, be it for treatment for hypertension or for any other indication. Okay. Every now and then, if they've got home blood pressure meter, it's always important to bring back to calibrate against the clinic meter, particularly if they want to verify if they are presenting with quite poor hypertension or not. On the reverse, there are actually people with blood pressures that are higher at home, and that's called masked hypertension. When they come to clinic, the blood pressure is normal, but when they're at home, the blood pressure is raised, right? So those are situations where you want to ascertain whether it's the blood pressure inaccuracy, the meter's inaccuracy, or whether it's a true disease condition that's going on there. So as part of your BP practical, we have put a link inside in the pre-reading on how to monitor home blood pressure. This is actually a nurse in the Singapore Polyclinic setting teaching patients, instructing patients how to monitor home blood pressure. This is very important to watch in your own time, because I feel that it's a very core skill for pharmacists to advise patients on home monitoring. And this will actually be rehashed in the 2151 skills lab. Okay, so I want to leave you with this concept of a blood pressure chart monitoring or log for your patients. It's very important to teach them how to monitor their own blood pressure and also track them, write them down. And also, because we tell them to average 2 readings at one sitting, it's also critically important to give them a chart where there's at least 2 readings that they could record, then also written instructions to guide them. For example, we tell them to take first thing in the morning, 1 to 2 minutes apart, right? That's what we want to tell people to do. Okay, the top multicolored chart, I find it very useful, mainly because it tells you what are considered good and not good blood pressure readings. And as you teach your patients to monitor blood pressure in the log through time, they also start to learn how well their modifications are with respect to their blood pressure responses. So in these readings, it can also encourage the patients themselves as they track their own readings through time, and then it can serve as a form of affirmation for them as well. Like maybe if they were successful in losing weight, or they're successful in controlling their salt intake, they can see their blood pressure lowering with time, and that actually encourages the persons to be compliant. Okay, so the good parts about this chart is the reference to guide patients on what the categories are. It's got simple written instructions on the headings. It's also got guided columns with date and time. And also for patients with hypertension, you might want to consider writing their specific targets for them, or individualized therapy or targets for them. In this setting, for example, I've written there target BP is less than 130 over 890, and call me if they're feeling dizzy. Sometimes I've got patients whom we are using medications for, that we're starting them for the first time, and they've maybe had very bad experiences before because they've got postural hypertension. So this is situations where you can write simple messages for them so that they have a reference point and not subject it to their memories. I don't think it's fair for us to subject it to the memory of patients all the time. Okay, so that sums up our preparatory lecture for IC4. So I'll see you in class soon.